Unfortunately, most of the time when I talk about nystagmus, most eye care professionals go to lunch. They don't want to deal with nystagmus at all. They're just not happy with having to see these patients, except maybe if the eye could be still so they could do surgery on the eye, and so it wouldn't wiggle. And what I'm going to share with you is, let me turn this off. Oh, I'm sorry. I'm going to share with you quickly a management of infantile nystagmus. And I'm going to touch again on some basic principles very quickly so that we were on the same page. This is a book here on the right. I have very little interest in that book. I don't think it's going to make me a fortune. My kid said the only way it would make any money is if they made it into a movie. I don't think that's going to happen. So I'm not going to make any money on this book. But this is, Lou and I have put together, Lou Deloso has been my science partner for many, many years. And he just recently retired, and we put this together prior to his retirement. So this has all of the information that I'm going to share with you today in it. So again, it's just dovetailing on what I had talked about before, the classification of nystagmus based on this classification of eye movement abnormalities and strabismus are those you see here. And the three types of nystagmus most commonly seen in infancy and childhood are the three on the right, and the other types of nystagmus are on the left-hand side. The reason that I understand a little bit more about patients with nystagmus is certainly not because I'm not any smarter than anybody else. I really am humbled by this patient population. It's because I see a lot of these patients. I see about 15 to 20 a week, and I do extra testing on them and have been for many years. So I'm going to share with you the testing that we perform, both on the afferent and the efferent side. The efferent testing involves eye movement recordings, which are the squiggly lines that allow us to dive into how the brain is malfunctioning in this disease. And these squiggly lines are as important to those of us who study the oculomotor system as EKG or EEG or ERG are to their respective specialties. We use infrared remote, video remote recordings now that you see down here on the right. This is infrared, and this is the magnetic search coil, and this is contact EOG. The systems now are really compatible with routine clinical use. We also perform a full evaluation of the afferent system on each patient, as much as they'll let us awake and some when they're asleep, including behavioral acuity testing, color, visual fields. We do OCTs now on all the children, and ERGs and VEPs. So we try and evaluate the afferent system as well as the efferent system. The thing that makes infantile nystagmus syndrome, again, this is not congenital, they're not born with this, this develops in the first 2 months of life, not a diagnostic dilemma is with eye movement recording, there's no other oculomotor disturbance that displays a slow phase that goes away from the saccade, which is the corrective phase. And what I mean by that is seen here. So these are the squiggly lines, the major waveforms of nystagmus, and the up is to the right and down is to the left in most conventions. And up here to the left you see a pure pendular waveform, up to the right is a pure jerk waveform with a linear slow phase. These two waveforms are seen in almost all forms of acquired nystagmus, here and here. All these other waveforms are part of infantile nystagmus, and this is the classic jerk with extended foveation waveform. That's only seen, these waveforms are only seen in infantile nystagmus, and they're usually present within the first few weeks after the development of the oscillation. So these waveforms can be diagnosed at 4, 5, 6 months of age. And if this diagnosis is made, unless there's some other indication to get an MRI, the children don't need an MRI for their eye movements alone. The other peculiarity of infantile nystagmus, and this is missed, and we spent a lot of time writing about this, and we wrote about it in the book and trying to emphasize this when I teach, is 17 to 33% of patients will have a spontaneously changing direction or intensity to their infantile oscillation. If you watch this girl closely, in addition to her deviation, she has esotropia. She also her nystagmus will also be increasing spontaneously in intensity. This spontaneously changing direction and or intensity is called infantile periodic or aperiodic alternating nystagmus. 17 to 33% of patients will have this. About a third of patients with albinism and 17% of patients without. And it will affect the patient clinically. This is what the eye movement recording looks like with a pure PAN. infantile PAN patient over about 10 minutes. This is jerk left. These are the fast phases. This is the velocity of the fast phases. So this is jerk left. It slows down, almost stops, jerk right, slows. Look at the regularity of this rhythm. There is no biological rhythm in the intense jerk right fixation. And that's the particular time when Chota Beam comes on the TV, they're going to turn their face to the right here. If the child is interested here at Chota Beam, their face is going to be straight. If they're interested here, it's going to be left. So this whole period of time takes about 3 to 5 minutes. So at least in the United States, the typical ophthalmologist will walk in the office, examine the child, see the face right, write that on the chart, and say, I'm going to do surgery for a right face turn. And then they see the child maybe pre-op, and they're here, and they're looking at their notes, and you don't know. So you have to look at the child for 5 minutes, which in the United States, 5 minutes is usually about 15 to 20 patients. And so to look at one patient for 5 minutes is unusual and practice changing. The visual system is also affected afferently in many of these patients. This is one of my patients with typical oculocutaneous albinism with some macular pigmentation, otherwise completely hypoplastic pigmentation of the choroid and RP in the periphery, and some optic nerve dysplasia as well, and also foveal dysplasia. The other form of nystagmus that's most common is fusion maldevelopment nystagmus. It used to be called latent nystagmus or manifest latent nystagmus, and it's diagnosed in the presence of early onset strabismus with linear and decreasing waveforms. So this is a typical child with monofixation syndrome and presence of fusion and stereopsis, but as soon as we cover one eye, the esotropia becomes larger with alternate cover than cover-uncover, and you can see her oscillation becomes more intense. It looks like she has no oscillation under binocular conditions, but as soon as you cover her, she gets jerk left, and then you cover the left eye, she gets jerk right. So this used to be called pure latent nystagmus. But when you record these patients, none of them have pure latent nystagmus. It's very rare. Under binocular conditions, there's still jerk left nystagmus, fixing with her left eye, even under the monofixation sensory system. It gets worse when you cover the right eye, jerk left, and then it changes to jerk right with the right eye viewing, and you can see the linear slow phase is diagnostic of FMNS. So how do we treat these patients? Medical, optical, and surgical treatments. Medical treatments, non-surgical treatments include medications, VT or orthoptics, acupuncture, biofeedback, vibratory stimulation, prisms, telescopes, and contact lenses are very important. There's 4 advantages to contact lenses in patients with infantile nystagmus. The first is the quality of the world is better. Everyone who goes from spectacles to contacts realizes that there's a quality. It's usually in contrast or in types of acuity that are related to high spatial frequency Snellen, but are vernier acuity. If you test vernier acuity with or without contacts, you see that they can improve almost an octave. The second is that if the child does have a head posture, they can use it and not have to look out the sides of their glasses or top, up, or bottom, even with a small head posture. The third is that you can tint the lenses or peripherally paint them, which reduces light interference and light sensitivity. Light sensitivity is pain. Light interference is the effect of trying to view the screen with all the lights on in the room. That's what patients with albinism have as a result of diaphanous iris. And the fourth is that the actual physical contact of the contact lens with the cornea slows the nystagmus. It's a powerful, powerful tool for these patients. Medications, the 3 top that I use, and I use these regularly. I prescribe these regularly for patients. Memantine or Namenda works very well for acquired pendular nystagmus. About 2/3 of the patients with APN, mostly due to MS, will improve with Namenda. Ampyra is 4-aminopyridine, and this is used mostly in MS to help walk, but it also is excellent for downbeat and upbeat nystagmus. And the third is baclofen. In half of the patients with periodicity or aperiodicity, if you give them baclofen, it will wipe out the periodicity or aperiodicity, and they won't have the head going back and forth, and they won't have the periodicity. They'll have the baseline infantile nystagmus. So these are very well tolerated by children, too, these drugs. But you have to talk to the pharmacist because they don't like to prescribe the 4-aminopyridine for nystagmus or the memantine. Memantine you can get away with a little bit more. But what about surgical treatment? Well, this is Anderson's quote in 1959 that when he operated for head posture changes, he did the recessions, and then Goto and Kestenbaum added the resections for the R&Rs, that in 1959 that the head position improved and vision. It wasn't until the late 70s that Lou DeLosso and John Flynn and Boston Palmer recorded patients and showed that the nystagmus, in fact, had improved, Then it wasn't until the 90s that Lou and I did animal experimentations trying to understand what it was about the surgery itself that caused the nystagmus to improve. And what it turns out is that it's the cutting of the extraocular muscle at its enthesis, or where the tendon becomes sclera and sclera becomes tendon. And we did this with animal experimentations. These are achiasmatic Belgian sheepdogs who have nystagmus, and we did all of these pre- and post-operative evaluations after horizontal rectus tenotomy. And then after the dog studies, we did 2 human trials showing that pre- and post-tenotomy and reattachment of the horizontal rectus muscles, there was a significant change in the oscillation itself. And as a result of that, and hundreds, thousands of operations later, I've come up with an operation scheme I'm going to show you. But this is a typical patient with albinism with a chin-down head posture. Here's the preoperative recordings. And then here she is post-operatively with her head straight, and the post-operative recordings. Now I'm showing you one of the really dramatic ones and improvements in this as a result of the surgery. So I've broken down the operations into 9. The 9 break down into common types, and you'll see the percentages of those operations down here. The most common operation in about 1 out of 5 patients is for a horizontal head posture, and this is very simple, one that you guys have done all the time. And this is a horizontal resection and recession. The recessions are in red, and I use these numbers for for a 40 degree, and then I use the Andersons with tenotomy for less than 20 degree head turn. Operation 2, 60% of the time, this is really underdiagnosed. Many albinos, many patients with afferent system disease due to congenital retinal disease or optic nerve dysplasia will have chin up and chin down positions. And for chin down, I choose to operate on the superior rectus and the inferior oblique muscles. Oh, they're coming up. There they are. Sorry, they're in blue. And I add one of the horizontals, either the medials or the laterals, and you can actually do strabismus surgery on those if the patient has strabismus in itself. The third is for strabismus alone. The patient has nystagmus plus strabismus. And most people will do a BMR recess or an R&R in one eye. Well, if you add the other 2 horizontal muscles, then you'll operate for the nystagmus plus the strabismus. As a matter of fact, most ophthalmologists have been treating nystagmus unwittingly for decades by doing strabismus surgery on patients with nystagmus. So operation number 4 in about 10%. This seems to be confusing to a lot of people, but it's actually the easiest. And this is a head posture plus strabismus plus the nystagmus. One of the eyes always drives the head posture. So if you straighten the head using the fixing eye, and then you straighten the eyes using the non-dominant eye, then you will fix the patient. And so this patient has an esotropia with the right eye fixing and adduction, so you do an R&R in the right eye to straighten the head. Just put base out prism over here till the head straightens. And then you can put base in prism or base out over here till the eyes straighten, and then you do an R&R in the left eye for the residual amount. So it's a pretty simple technique. Operation number 5 is for chin up. I see this less, but still commonly, and I choose to do superior oblique tenectomies and inferior rectus recessions. The reason I use the obliques and the inferior rectus is that there's less development of alphabet patterns as well as torsion, and there's a equal limitation of gaze, about 10% across gaze horizontally. And I'll add the horizontals or either the medials or the laterals, depending upon whether there's an associated strabismus. If there's no strabismus, you can just take these off and put them on, do tenotomy with reattachment. If there's no head posture, no strabismus, no convergence stamping, then this is the operation which we performed on the animals, where you take all 4 horizontal recti off and just reattach them for the nystagmus, and that's only in 9% of patients. So 91% of patients will have some other reason to do eye muscle surgery other than just the nystagmus. These are more complicated, 7, 8, and 9. There's a lot of ways to approach this operation where they have a big face turn and a big tilt. This one you can approach, and about 3/4 of the patients will respond to just this one operation where I do a recess resect in Anderson-Kestenbaum fashion and then offset the horizontals vertically to help with the chin, the tilt. This is a patient with convergence stamping. This is the single most powerful operation for nystagmus. Unfortunately, it's only available in 6% of patients because 40% of patients will damp with convergence, and most of those will have strabismus. So if they don't have good fusional vergence, you can't create an exodeviation and ask them to verge. They'll just become exotropic. So what I do with these patients is prism adapt them in the office, to 14 to 16 base out with prisms in the trial frame. Add a little minus, a minus a quarter, minus 50 for the accommodation induced by the convergence. And if their nystagmus improves, their acuity improves, and they're tolerating the prism in the office for a half hour, then you can do a BMR assess for the prisms you adapt with BLR rectus tenotomies. This is a very powerful operation. The last is for a pure head tilt, and I've stolen this from von Norden, who did this operation, and I use this. This is a horizontal offset of the vertical recti. And this works very well, although it's harder to change. That's the hardest one to make better is the tilt. The nystagmus improves, but the tilt sometimes requires other surgery or doesn't improve as much as we think. These are the things that have improved as a result of analysis after the surgery. So these are conclusions that independent of the reason you're operating, the nystagmus improves, and it improves because we're attacking the enthesial area here. So how is that going to help me in another way? Well, to make a long story short, there was some patient on oral carbonic anhydrase inhibitors. We studied them, and the nystagmus got better. I put him on a topical carbonic anhydrase inhibitor. His nystagmus get better. So we did a clinical trial of patients where they were given placebo for a few days, washed out, and given topical brinzolamide for 5 days and washed out. These are the 5 patients. They were on the drop 3 times a day. I know this is difficult to see, but this is in the publication. And these are their eye movement recordings on placebo, on the baseline, and then on the AZOP. And all of the measures of their nystagmus improved on the AZOP. This is their nystagmus acuity function as a function of gaze, right and left. This is a very important functional characteristic, that their vision improves away from the null zone after you treat them surgically as well as medically. And up is better and down is worse. And placebo and baseline are down here, and this is AZOP, which has improved their NAFX across gaze in all patients. 4 out of the 5 patients had improvement in their vision. The IOP went down predictably because brinzolamide is a IOP-reducing drug. And the overall group mean acuity improved by 1 logmar, even though 1 did not improve. And I've been using this medication now, and we're studying this prospectively, although the small trial showed that topical AZOP does help. The last thing is that we also are working on a much more powerful medication back with the dogs. This is Ginger. She has RPE65 deficient retinal disease, and you can see her high-frequency pendular oscillation. This is her brother Scout. And a patient of mine got an accidental environmental agent in his eye, which helped his nystagmus, and that was almost a decade ago. And I've worked on that medication and have patented it and are now using it in a clinical trial after we did the trial in these dogs. Here's the dogs getting recorded. Sorry. Here's Ginger getting recorded, eye movements, and we put the drops in. This is pre-op, and this is post-op. If you look here, you'll see the recordings. Pre-drop, I'm sorry. And this is post-drop, and these are functions of her nystagmus, and her nystagmus has almost disappeared as a result of the use of this medication. And we're just planning a clinical trials in humans, and this is Ginger, who we've adopted after her experiments. She's here with Phil. All of this white stuff, that's all snow in our backyard in Akron. And this is Ginger's retina. So what we've shown by studying nystagmus is that we have a key into how the brain works, and that we may now have new methods for intervention, not only in nystagmus, but possibly other oculomotor disorders. I know I went over this a lot of stuff, but I wanted to give you a sense of what I do with these patients, how I treat them, and how we manage them, how you can incorporate this into your practice. We don't have to send them away anymore. I think that they deserve the benefit of our knowledge and our treatment. Thanks for your time.